Good afternoon, and welcome to today's webinar, Implementing Procalcitonin, a Team Approach. I am Kerry Denham, and I'll be your moderator for today's event. We are delighted to bring you the Thermo Fisher webinar series presented by AACC and supported by a generous grant from Thermo Fisher. This program is accredited for Accent Continuing Education Credit. I'd like to point out that our webinar session will conclude with a Q&A session. You can submit your questions at any time during the webinar through the Q&A dialog box in the bottom right-hand corner of your screen. However, questions will not be answered until the Q&A portion of our program. Please note that there is a Q&A dialog box as well as a chat dialog box. To ensure your questions are received and included, please submit your questions through the Q&A box. To check that your Q&A dialog box is open, please confirm that the Q&A box is visible on the right-hand side of your screen. If it is not, click the Q&A icon from the options in the bottom center of the screen, which will turn the icon blue. Your Q&A dialog box will then become visible. So let's get started. Thermo Fisher is committed to providing healthcare professionals with education to help them make informed decisions in the management of their patients. As a provider of assays and instruments for disease markers of diagnostic interest, Thermo Fisher is dedicated to expanding clinical insight based on evidence, analysis, and clinical judgment. Again, thank you for joining us for today's Thermo Fisher's webinar, Implementing Procalcitonin, a Team Approach. Our speaker, Dr. Robert Fitzgerald, is the Director of Toxicology and Associate Director of Clinical Chemistry Laboratories at the University of California, San Diego Health. Dr. Fitzgerald received his bachelor's degree in chemistry at Loyola College of Maryland, followed by his PhD in pharmacology, toxicology at the Medical College of Virginia, Virginia Commonwealth University. Currently, Dr. Fitzgerald is a professor in the Department of Pathology at the University of California, San Diego. His research interests focused on biomarkers and the use of mass spectrometry in the clinical laboratory. Dr. Fitzgerald, we are delighted to have you with us today, and you may now begin your presentation.
Thanks very much, Kerry. It's a pleasure to be here. Thanks to everyone who's dialed in to hear about our experiences with implementing Procalcitonin. Not going to tell you that we did everything exactly right, but it is a journey, and I think that there are some valuable lessons that we can talk about as we move forward. So clearly it is a team approach, and I was lucky and fortunate to have a group of clinicians that were intellectually interested and willing to spend the time to help implement Procalcitonin. So it clearly was a team effort, and I'll describe some of that as we go through. So why were we interested? That's one of the topics we're going to talk about. Briefly, to talk about Procalcitonin background. There's a lot of data published on Procalcitonin, and it's necessary to understand some of that as you go about considering implementing Procalcitonin in a clinical laboratory. Talk about our implementation strategy, what worked, what didn't work, some of our monitoring protocols, and really the story is a continuous improvement project as we collect data and see how it's impacting patient care. I didn't know this until about a year ago, but it was actually one of my mentors who first discovered Procalcitonin. So this is a picture of Dr. Len Deftos in his VA office. Spent many hours up there talking science with him. He was a noted endocrinologist, physician scientist, who actually was studying calcium metabolism. And the data on this slide shows this is fractions. So this was a chromatography that was being analyzed by an immunoassay. So he's collecting fractions, and he was looking for calcitonin, and he noticed calcitonin was coming out around fraction 15, but he also noticed that there was a late eluting larger molecule that was coming out subsequently that was immunoreactive with calcitonin. He did further what he calls chase experiments where he was using a radio label, and he demonstrated that calcitonin was a product of this precursor molecule, which he termed procalcitonin. So that was in the early 70s. He termed that, he coined the term procalcitonin. At the time, he didn't know its relationship to disease because he was really focused on studying calcium. About 10 years later, Charlie Hawker's lab demonstrated it for the first time in toxic shock syndrome, where these patients were becoming hypocalcemic, and he was the first to demonstrate that it actually was procalcitonin that they were measuring. So subsequently to that, Brahms developed the immunoassay to procalcitonin, and we'll just cover a little bit about what is the molecule. So sort of two functions or two relationships of procalcitonin. One is with relationship to calcium metabolism. Procalcitonin gets processed into calcitonin by the thyroid gland, and calcitonin really has an endocrine or neuroendocrine function of antagonizing parathyroid hormone and vitamin D. So it acts to lower calcium concentrations in circulation. Procalcitonin itself does not modulate calcium metabolism. It is produced by an inflammatory response, particularly due to bacterial infection, where a variety of different tissues produce procalcitonin, and we'll review that in just a second. So in the setting of a bacterial infection, procalcitonin becomes pathologically secreted from a variety of tissues. A good cartoon for that would be, this is the normal function for calcitonin. So in the thyroid gland, the C cells of the thyroid gland, the calcitonin gene is transcribed into messenger RNA, which is translated into procalcitonin. In the thyroid gland, there are proteins that further process procalcitonin into the biologically active calcitonin, which is packaged in the Golgi, and vesicles are secreted in response to either gastrin or to elevations of calcium to maintain calcium homeostasis. So that's the normal secretion pattern for calcitonin. In the presence of bacterial infections, bacteria releases endotoxin or lipopolysaccharide, which stimulates interleukin and tumor necrosis factor. These upregulate the gene expression of the calcitonin gene. We increase messenger RNA for calcitonin, which actually produces procalcitonin. Things like fat cells, kidney cells, liver cells, pretty much every cell studied produces procalcitonin in response to a bacterial infection. So these other tissues don't have that final enzyme that produces calcitonin, so they release the procalcitonin molecule by itself. So second really important point pointed out by this paper was that viral infections increase interferon gamma. Interferon gamma actually blocks the production of procalcitonin and really is the main driver, and one of the main interests in procalcitonin is that it's primarily elevated in bacterial infections but not viral. So that is a key differentiator. Clinically, those infections are difficult to differentiate, and that's where procalcitonin can potentially play an important role as a biomarker. So bacterial infections stimulate production of procalcitonin. It's rapidly released into the bloodstream, and viral infections don't increase procalcitonin. In fact, they are antagonistic to it. So looking at the upregulation of the gene expression in sepsis, it's 10 to 100-fold in a septic patient, and it's widespread, so it happens in a variety of different tissues, as shown by this slide. This is looking at mRNA regulation, so upregulation of mRNA for the calcitonin gene. In sepsis, you can see that virtually every single cell studied, you get an upregulation evidenced by these white tracings in sepsis that is not present in control tissue without without a bacterial stimulation. The other good thing about procalcitonin is that it comes up rapidly after an infection. So this was a group of normal subjects that actually were injected with bacterial endotoxin at time 0. And you can see by 4 hours, we start to see an increase of procalcitonin. It's markedly elevated at 6 and 8 hours. It sort of plateaus. And then if the bacterial infection is controlled, it will drop off with a half-life of about a day. So those are time frames that are actionable in an ED or in an ICU. So understanding procalcitonin, the reference range is less than 0.08 nanograms per mil. Most people, it's undetectable. Becomes elevated within 3 to 6 hours. Peaks, as we showed in that previous slide, around 12 hours. And basically, if it falls, if the procalcitonin falls, it is indicating successful control of the bacterial infection. If not, then maybe there needs to be different antibiotics or further care. As far as how does it disappear, there are proteolytic enzymes in circulation that cleave it up. It also has some renal clearance. And as we said, it has a half-life of about a day as a general time frame. People look for it to decrease by 50% in a day, being indicative of successful control. So Brahms is the first manufacturers to come up with a procalcitonin assay that was clinically approved. And this slide I don't particularly like because the lawyers got a hold of it. When I'm telling the residents how to give a talk, this is exactly what I tell them not to do, is to have too many words and too many bullet points. But when you talk about FDA claims, it has to be fairly specific. So as shown on the slide, initially it was aid in short-term risk assessment, so first day of ICU admission. And that's not particularly exciting to most docs. And the second claim was a long-term, a 28-day all-cause mortality. Again, most of the docs that I interact with, these are useful, but they want a biomarker that actually tells them to do something. And so the next two claims have been really critically important for actionable biomarker results. So this claim is basically saying aiding decision-making on whether or not to put somebody on antibiotics in lower respiratory tract infections. So that's going to be something you're going to hear several times during my talk. PCT seems to be most effective and also the best demonstration for efficacy is in lower respiratory tract infections. So figuring out whether or not you want to put someone on antibiotics. And then the final claim is antimicrobial stewardship related. And again, another key driver for the utility of procalcitonin is antibiotic discontinuation. And so based on monitoring serial PCTs, considering stopping antibiotic therapy, a sea change, so a really important actionable result for procalcitonin. So why was UCSD interested in procalcitonin? Our research lab had been using procalcitonin for a number of years. It was pretty clear that it was good in distinguishing bacterial from viral infections. It also had some utility in heart failure patients, and I'll show some data on that later. Good publications supporting its use in guiding antimicrobial use. And at the time, we didn't have the ability to bring in a separate analyzer just to run PCT. It was only available on one analyzer. Recently, it's become available on a variety of platforms, including the one that we use here at UCSD. So as a send-out test, it wasn't very useful, but once we have it in-house and can provide a rapid turnaround time, it becomes a lot more clinically useful. So why is it useful? It's clear that overtreatment with antibiotics is problematic. One of the first things you learn as a PhD student in pharmacology was bacterial resistance and how you actually develop that in vitro by adding antibiotics. It's easy to demonstrate that. C. difficile, the highest cause of C. difficile is antibiotics wiping out the normal microbial clusters in your GI tract. They also have direct toxicity, so ototoxicity, renal toxicity, a variety of toxicities. So if they're not needed, they shouldn't be used. I'll show some data on studies that demonstrate PCT is improving outcomes, and some studies don't show that. So it's not completely clear, and I think what that speaks to is how you implement it in your laboratory. So that's sort of the whole point of this talk. As we said before, the best evidence is for respiratory tract infections. As a PhD student in pharmacology, we were taught that it was really important that patients took all of their antibiotics. So you take till the very last pill is gone, and typically courses were 7 or 14 days. And so the question is, why is that? Dr. Spellberg wrote this an opinion piece in Journal of Hospital Medicine, and I thought was very kind of funny, but it's also true. For decades, the standard antibiotic course for most acute bacterial infections has been 7 to 14 days, based largely on the fact that a week has 7 days in it. The reason the week has 7 days in it dates back to an edict issued by Constantine the Great to underscore the absurdity of basing 21st century antibiotic course durations on an ancient Roman emperor's decree. I refer such durations as Constantine units. 1 Constantine unit is a 7-day course of antibiotics, and 2 Constantine units is a 14-day course. He goes on to point out that that's kind of ridiculous, and that there are things that we can do to change that, and PCT, I think, has a role in that. So Surviving Sepsis campaign in 2016 recommended discontinuing antibiotics if patients were improving, and they suggested that PCT is an appropriate biomarker to help make that decision, concluding that decreased PCTs can be used to stop antibiotics. The CDC also is concerned about antimicrobial use. 30 to 50% of antibiotics as an inpatient are inappropriate. How can we fix that? As we said, it drives resistance, they have toxicity, and antimicrobials are the key driver for C. diff infections. So just a quick review of a couple of slides. This was a European study looking at 1,500 patients who were randomized into PCT-guided therapy versus standard of care therapy. And we'll talk about what the guides are. They're available. University of Nebraska has it on their website. There have been a couple of publications, and pretty much people use very similar things. But what you'll notice is that antibiotic consumption, so antibiotic exposure, they did 3 different measures. They were all significantly different. The mortality rate, which is also probably the key driver, both short-term 28 days and 1 year were significantly different, with the PCT-guided group being lower. There were more adverse events as far as reinfections, 5% in the PCT-guided group versus standard of care. But really, I think what speaks to the point is what is the long-term mortality, long-term and short-term mortality. So conclusions of this was clearly PCT-supported therapy can decrease antibiotic consumption. Mortality was decreased in the PCT group, but reinfections were higher. And so there is clearly a difference between what happens in studies and what happens in routine clinical practice. And so how do we translate these really strong findings into routine clinical practice? And again, that speaks to how you implement procalcitonin in your hospital setting. So this was a Cochrane analysis of 26 different studies, and by one of our other speakers in this seminar series, and showed that in 3,000 patients who were randomized to procalcitonin versus 3,000 in the control group, that 30-day mortalities were significantly reduced, that the antibiotic adverse related events were significantly reduced, and overall exposure to antibiotics was reduced. So fairly robust study from a variety of different hospital settings showing efficacy of procalcitonin in de-escalating antibiotics. So both as far as reducing antibiotics as well as outcomes. So conclusion of that study was shorter duration of antibiotics with PCT-guided therapy, less adverse events, and a lower 30-day mortality. So that's all positive. Those are things that we'd all like to have in our hospital. As I said from the beginning, not all studies show a positive benefit of procalcitonin. So this is a New England Journal of Medicine paper, and I liked it because I thought the diagrams were cool. I didn't understand them, but it took me a while. Basically what they're showing is a procalcitonin randomized group compared to a usual care group and number of antibiotic days. So the primary outcome that they were looking for was decreased antibiotic use in the PCT group. And they call these violin plots. This yellow bar is the median number of days of antibiotic therapy. You can see that they're pretty much the same. This is the lower 25%, the upper 75th percent. So those exactly overlap. And even though this is a complicated violin diagram, it's pretty easy to see that there's no difference between procalcitonin and usual care. And so this was a U.S. hospital study, 15 different hospitals, and I think really shows that if it's not implemented properly, that you don't get the full benefit of procalcitonin. So people argue about, pluses and minuses of all studies, but it does show that how you use the marker clearly has an effect on outcomes. So what was our strategy? So when it became available on our platform, or was coming close to becoming available on our platform, I convened a group of ED docs, of the sepsis protocol team, hospitalists, PharmDs who specialize in infectious disease, as well as infectious disease physicians. Just to have a conversation, are we interested in implementing procalcitonin here at UCSD? And some of them, the ED, were excited about it. Some of the infectious disease docs were not convinced. And so we decided to do a small pilot project. Lots of data we realized had already been published. We didn't want to recreate things that have already been published. We just want to see how would it work in a short-term project at UCSD. So for a month, we collected data, gave us a chance to work out the infrastructure of IT, setting up the assay, getting control values, et cetera. We reviewed the data, we did some educational offerings, and as you'll see, we were convinced that the assay offers potential for improvement here, so we offered it in a live environment. After we put it into production in April of 2017, I guess last summer, we looked at the data to see, are we making a difference and can we make further improvements? And so we realized at that point that yes, clearly we had not given the best guidance on the use of the test, and that we could improve in that department. So we updated our guidance, and we are following that data currently. So the pilot project, about a month and a half, again, just trying to demonstrate the feasibility of using procalcitonin here at UC San Diego. Basically, anytime a sepsis protocol was activated, we included that patient. We got a PCT on day 1, 2, 4, and if they were still around day 7, so a low end. Again, we were just trying to set the assay up and see, briefly how it would potentially work in our hospital. We looked at the charts of those 42 patients to determine outcomes, and important to note is that the treating physicians were blinded to the PCT results. So there were 2 docs that were, one was an ED doc and one was in the hospital, who were following these patients and making sure that the PCTs were ordered, and treating physicians did not know the PCT results, so they were blinded to them. So a couple of things fell out of it, and I'll give you a summary at the end, but a couple of quick case studies. This patient was a 34-year-old female with leukemia, came in with low-grade temperatures and leukocytosis, and no obvious source of an infection. So they were concerned about developing sepsis, so they put her on antibiotic, even though they didn't know exactly where the infection was or what it was. So over the course of 3 days, her PCT was 0.1, 0.11, and 0.08. So we say our reference range is anything greater than 0.08, but clearly these are all very low levels and indicating that there really isn't a serious bacterial infection and probably no need for antibiotics. Her cultures grew a coronavirus, so she had a viral infection and not a bacterial infection. Fortunately, she developed watery diarrhea and C. difficile was detected, so that's consistent with wiping out her microbiome and C. difficile infection taking over. So that's takeaway points from that case. This would have been an example where if the provider paid attention to the PCT results, they could have stopped the antibiotics after the first day. And clearly is a showing what's well known that unnecessary antibiotics are increased risk for C. diff infection. Continued low levels of PCT, less than 0.25. So this patient was bouncing around about 0.1. So should make providers think about stopping antibiotics. Second case was a possible pneumonia in the ED, admitted for sepsis. 64-year-old male with a prior MI. He had some heart failure, so his ejection fraction was low. He had a cough, shortness of breath, so signs and symptoms of either developing sepsis or worsening of his heart failure. So was this pneumonia? Was it a viral pneumonitis? Or was this just exacerbation of his heart failure? So the CBC was about 10. He had a chest x-ray that was inconclusive. It was either a possible infection or it could be a partially collapsed lung, but there was no culture data. So he didn't grow out anything positive in his cultures. His PCD on day 1, 2, and 4 were all negative. So these are very consistent with lack of a bacterial infection and no need for antibiotics. Yet he got 10 days of antibiotics. He was prescribed 10, and he ended up taking 10 days of antibiotics. So take-home points from case number 2. Lower respiratory tract infection is really where PCT works the best, and this was a good example of where, based on the initial results, and at least the second-day results, then antibiotics probably were not necessary. So PCT less than 0.08, very unlikely bacterial infection. Clearly is good evidence for safely discontinuing antibiotics. Previous work in our research lab, Dr. Mazel's lab, looking at heart failure patients with low PCTs, patients who got antibiotics did worse than patients who did not get antibiotics. And so that's consistent with other things. If it's not bacterial, you don't want to be putting patients on antibiotics. Case number 3 was a case, really a case of noting the caution and proper interpretation. So this was a surgical site infection. 47-year-old with sleep apnea and hypertension, had a recent surgery, and it was clear that the wound was infected, it was inflamed, there was an abscess. So it really wasn't in question whether or not she had an infection. Lab showed elevated lactate, leukocytosis, but her procalcitonin was normal, so it was less than 0.08. So here's the case where we know we have an infection, but the procalcitonin is negative. She got put appropriately on antibiotics, and she had a staph infection that cultured, so she was treated appropriately by the antibiotics. So a good reminder that we treat the patient and not the lab value. So this lab value would say no infection, but it's clear from the patient's presentation that she has an infection and needs antibiotics. So what happens here? So she completes the antibiotics and did fine. What do we want to remember? One of the limitations of PCT is that localized infections, it doesn't become elevated. So this was a localized infection, and consequently her PCT was in the reference range. So as we said, we're going to interpret the PCT in the context of the patient. So, and that holds true regardless of what protocol you're following. So conclusions from our brief pilot study, 42 patients over a month and a half that had sepsis or at least were in the sepsis protocol. All patients received antibiotics on admission. 35% had a PCT less than 0.25. So that's one opportunity. We had 3 cases of C. diff. Could they have been prevented? We don't know. They didn't have, they developed C. diff after taking antibiotics, and that is a clear opportunity for improvement. Significantly elevated PCT or PCT not improving were associated with a high risk for ICU. So that's the risk assessment that it has the claim for, and that makes sense based on all the other data that's been published. So there was 3 cases of confirmed viral infections that got 10 days of unnecessary antibiotics. So our conclusion was that it offers a possibility for optimizing therapy. It doesn't prove you can optimize therapy, but it offers the possibility. And so we decided to make it available with a rapid turnaround time starting in April of 2017. So several months after making it available here at UCSD, last summer we collected post-live follow-up data, and I'm going to share some of that with you. So it was a retrospective chart review, and basically any inpatient who had at least one PCT got reviewed. So 3 months, July to September of last year, and our outcomes and our definition. So de-escalation, we would say, was discontinuation of antibiotics for a PCT less than 0.25. So we wanted to see, did docs actually act on the PCT result, or were they just following it and not knowing exactly what to do with it? PCT concordant antibiotic use would be a PCT greater than 0.25, antibiotics when your PCT was greater than 0.25, and no antibiotics if the PCT was less than 0.25. A high-value PCT, it was a judgment call. Basically, based on a PCT, there was evidence that they discontinued antibiotics or somehow impacted patient care. So there was 205 unique encounters for 374 PCT tests. The mean PCT on presentation was about 3.7, so significantly elevated. Medians were probably more informative, really in the gray zone at the cutoff range, so right around the 0.25 concentration. The distribution of values is shown in this slide, so almost about half of them are 0.25 or less, and about half of them are greater than 0.25, and we'll see how we use this 0.25 and this 0.5 as cut points in our algorithms. Who was ordering it? It was being ordered primarily, the biggest user was internal medicine, the ED followed that, the ICU, cardiology, and all of these were appropriate services for ordering PCT. So it seems like at least it is the right, it's not, outpatient lab testing doesn't seem to be the bulk of it. So that was sort of encouraging. How many times were they getting PCTs? So on average, in our patient population, they were getting almost 2 PCTs per patient, and it varied depending on what service they presented to. Makes sense in the ED. They're not there very long. They were getting 1.3. Cardiology, the lab loves our cardiology colleagues. They believe in biomarkers. They use biomarkers, and they were getting about 3, following them serially. What were the syndromes that they were typically used in? So respiratory, as we said, that's probably a good use of procalcitonin. Sepsis, that's also a very appropriate use of calcitonin. We talked a little bit about heart failure and the utility of procalcitonin in deciding whether or not to put people on antibiotics or not, so an appropriate use. And then there was a smattering of other things. So again, seems like we at least have reached the right target docs. They're reaching the right target patients, and are we using the data once it comes back is really the next question. So of these patients, 90% of them had a culture within 24 hours of the PCT, and of that 90%, 30% of those had positive cultures. So the majority did not have a positive culture. What was it used for? So aid in diagnosis, that's what it's approved for. De-escalation and unclear. So really there was room for improvement here. Could we use PCT after the infection and after the initial decision to put the patient on antibiotics to de-escalate? Probably was one of our target areas for improving. So another case, 34-year-old male, known advanced systolic heart failure, ejection fraction of 20% at baseline, hypovolemic shock, and acute kidney injury. Procalcitonin is elevated, so it gets flagged and as a 0.21. And what was our initial advice? So this patient's going to be put on antibiotics. That sort of is, with that history and that result, that is a pathway that he's going to fall on. So here's what our initial advice to the providers was. And it's this long text thing that I think pretty much no one read. And so we decided, based on our initial preliminary results, is that this guidance, which came directly from the package insert, so these are FDA-approved claims, was not very useful. Our docs were also concerned that this is a procalcitonin at 0.09, it gets a flag. Procalcitonin of 61 also gets this flag. And they were saying, clearly these are different results and have different implications for the patient. Let's try to change this so the lower levels will just say it's elevated, and the exclamation will be for anything greater than 0.5 nanograms per mil. So that was an easy enough fix, and they were happy with that. So now this shows up. It's not sort of like a panic value, and in fact, we have no critical values for procalcitonin. So looking at the data, the discordant PCT use, we call that a high PCT and no antibiotic. Discordant was also classified as they had a low PCT and got antibiotic. So in that patient population, after we went live, 32% of the patients had discordant use, and 86% of those, vast majority, was use of antibiotics in a setting of low PCT. So here's our antimicrobial stewardship, and our antimicrobial stewardship committee. We're really excited about the potential of improving care based on these results. So it was clear that PCT is identifying things, but we're not optimized in our use. So how do we make improvements? So issues that we face related to IT, a single order versus a panel order, and we wanted to make that available. Was our initial panel correct as far as days? And are we monitoring at the correct frequency? Are we providing sufficient guidance? And we really decided that we were doing a poor job on both of these. And so we reconvened the clinical group, reviewed that data, decided that we weren't using PCT appropriately, that there was clearly, it was telling us things, but we weren't giving our docs very good guidance on how to use the data. So we developed a consensus based on the literature. So a lot of that was from websites, the University of Nebraska, and publications. We changed our draw times to 0, 24, and 48 hours. And this guidance, I'm not trying to take credit for. This is widely used at a variety of places. But it starts out with all cases, clinical judgment outweighs procalcitonin value for making treatment decisions. And that needs to be said, but clearly if we give them some other info, then they're going to potentially utilize the procalcitonin result better. So basically for lower respiratory tract infections, if the initial PCT is greater than 0.5, strongly recommend antibiotics. Between 0.25 and 0.49, we recommend antibiotics. 0.1 and 0.24 discouraged, less than 0.1 strongly discouraged antibiotics. There's really no need to put those patients on antibiotics. And you saw in our preliminary data, there were patients that were being treated by that that could benefit from if they followed this protocol. Septic shock guidance, we actually are a little bit different. So the initial procalcitonin, if it's greater than 0.5, it's the same, recommended 0.25 to 0.49. If clinical suspicion is high, antibiotics are recommended, and follow those serially, and if it's decreasing, use the de-escalation protocol. Less than 0.25 in a septic shock is unlikely to be bacterial, and consider alternative diagnosis. You could repeat PCT in 6 to 12 hours. If so, follow the de-escalation protocol. So we're actually now giving our docs a lot better information to act on. Here's our de-escalation protocol. If it's greater than 0.5 and rising, then we're going to continue antibiotics. Don't discontinue. If it's greater than 0.5 and it's decreased by less than 80%, so that's the other sort of FDA-approved cut point, is a decrease of 80% or greater. So if it's decreased less than 80%, continue the antibiotics. If it's between 0.25 and 0.49, or a drop by more than 80% from baseline, then that's a good indication that antibiotics have been successful and they can be discontinued. Less than 0.25, strongly encouraged to discontinue antibiotics. So again, much more actionable than our initial guidance data. So our current status, where are we? We are collecting data on the improved guidance. It's continuous data monitoring. We are going to evaluate that data for high-impact PCT values. How many times do we actually change patient care, and what do we need to do to continue to continue to communicate these results with the providers who are actually using the test? How many times are providers actually following our updated guidance and continuing to recruit clinical champions? So that's been hugely successful for us, is having an ED doc who was a champion, as well as an internal medicine physician, and the whole panel of the sepsis protocol and the infectious disease docs. So my collaborators on the pilot study were Dr. Neath, Dr. Wardy, and Amy Rockefeller, our CLS. They were keys in making that study, the pilot study happen. Post-live follow-up, Dr. Seaman, Huang, Firestein, Lin, and Wu also have been key to both implementing and monitoring and continuing to try to improve how we use PCT. So with that, I'll thank you for your attention, and I'd be glad to take some questions.
Thank you, Dr. Fitzgerald, for sharing this excellent presentation with us. I would like to remind everyone that you can ask a question via the Q&A box at the bottom right-hand corner of your screen. Make sure that you ask your questions through the Q&A box to ensure that we receive them. We have had a couple of questions already, and Dr. Fitzgerald, here is the first question. Thank you for your very interesting presentation, Dr. Fitzgerald. You mentioned that there were some issues with EPIC-LIS implementation. What about result reporting? Does a single reference range supply sufficient information when using or interpreting results with this biomarker?
So I think it's pretty clear with this biomarker, a single reference range is not very informative. And that was clear from our initial post-live follow-up. We practice medicine in a fairly conservative place, and I didn't want to make too many changes initially. We just wanted to see what the adoption was, and it became rapidly clear that we needed to provide additional guidance. So having a team of people that are going to be using the result involved was key, and using protocols that were available and had been validated in Europe, I think was truly key. And so instead of having that long blurb of text that no one reads, we actually have a link to the protocols, and I think we're going to see that we're actually have improved the care as we continue to analyze the data. So short answer is no.
Thank you. Here's the next question. Dr. Fitzgerald, you mentioned that educational offerings were part of the introduction of PCT. Can you please elaborate on what specifically you did to educate? Was it just for the clinicians ordering, or was education done for all interested staff, including nursing staff and laboratory? And who did the training?
So we found that the word training doesn't go over good with some physicians. And so we try not to present it as a training session. We try to present it as an information session, and our experience has been that it works best if ED docs talk to ED docs, and hospitalist talks to hospitalists, and intensivist talks to intensivist. And so that was part of the team approach, is that our ED physician, Dr. Wardy and Dr. Neath, we together developed a presentation that had data from our initial pilot study. So it's in our hospital, our own data that we can interpret in the context of published data in Europe and the US to show that, yes, in fact, this works the same here as it does everywhere else, and these are the patients that you're taking care of, and this is the potential benefit. So we had a variety of physicians that were talking to physicians. We developed the similar protocol for in the laboratory. We also had ED docs give nursing information sessions. So it's hard to do enough of that. Everyone's time is very busy, and it's hard to reach everyone. So we combine that with what we're doing in the EPIC record, as well as communications that that get sent out to the general population and get read somewhat, but probably not super effective.
Thank you, Dr. Fitzgerald. Here's the next question. Is PCT currently a part of your sepsis protocol or antibiotic stewardship protocol?
So we actually have a couple of sepsis protocols. One of them is in the ED. So the ED sepsis protocol, it is part of. The inpatient sepsis protocol, it is not part of, but that team is well versed in the use of PCT. They are, some of our champions. So it is available, but it's not part of the protocol.
Thank you. Here's the next question. What do you think the turnaround time goals should be for PCT?
So we don't offer it stat. We have a turnaround time in our hospitals of about an hour. So it's, that's in lab of an hour. So turnaround time from acquisition, I would say in the 2 to 4 hour range is certainly, useful.
Thank you, Dr. Fitzgerald. The next question is, how reliable are the PCT algorithms for sepsis? These algorithms were created in Switzerland with populations greatly different than the US, that is, less CKD. Patients going to the ICU could have cardiogenic shock, AKI, SP trauma, causing falsely high PCT.
Yeah, so I think that the protocols are not set in stone, and clearly if there are other things that are going on with the patient, then docs need to have the freedom to treat the patient appropriately. I do think that PCT, as evidence in our short little studies, showed the potential for utility in a lot of patients.
Thank you. Here's the next question. Is PCT orderable for outpatients too, or is it just for ED and in patients at UCSD?
So currently, PCT is available in outpatients. I don't have a good handle on how many times that happens or how that is being used. We do have a lab utilization committee, and we are going to be looking at that.
The next question is, it appears from your study this was not limited to the ICU. What are your thoughts about PCT in detecting infections? Do you feel the value of PCT is in its negative predictive value for AVX stewardship?
Yes, I do think that it's just negative predictive value. It's telling you, it's helping rule out a bacterial infection. And it's either helping you rule out a bacterial infection so that you can discontinue antibiotics. I think, the general protocols are going to be the same as that patients that come presenting with symptoms consisting with developing sepsis are going to be put on antibiotics from the beginning. But if their PCT is negative on the first draw and on the second draw, then there's good evidence that you could, if the patient is on the right trajectory, discontinue the antibiotic.
Thank you, Dr. Fitzgerald. The next question is, one of your slides showed the breakdown of procalcitonin orders by area. Do you believe you could get better patient outcome if the percentage of ER orders increased? This would allow easier focused intervention.
I'm not sure I can answer that question. I could guess, but it would be a guess.
Thank you. We're waiting for a few more questions. We have a few more minutes left. Okay, so this concludes our Q&A, and I would like to thank Dr. Fitzgerald again for providing this excellent presentation. And again, thank you for all the audience for taking the time and listening to this excellent presentation presented by AACC and supported by Thermo Fisher. If you missed out on any of the previous procalcitonin webinars, be sure to visit our on-demand webinar page to view a recording of it. Now, when you close out of this webinar, you will be taken to a short survey where on completion, you can gain your Accent Continuing Education credits. If you wish to listen to the webinar again, a playback link will be sent to your registered email within the next few days. If you have any questions following this program, please call our customer service line at 800-892-1400. Thank you and have a great rest of the day.